Annu, thank you very much.
Okay, thank you, Dr. Sharma. Hopefully everybody has to stay awake now.
Well,
For the
actually,
afternoon,
talking about
yeah.
stay awake, as you know, in the end, we still do the raffle.
Oh.
And with the raffle person will go home with the iPad. I think Kim is going to bring it. So that we keep the same tradition.
Thank you, and this is going to be what I'll be talking on. What is the current status of the structural heart intervention? So as we know, there are 4 valves, so aortic as well as pulmonic valve. The treatment already has been established. As we have seen, I think in the previous lecture, echo was helpful in many of these procedures. So tricuspid valve, both there is a valve ongoing trials for both the valve replacement as well as a clip, same thing with the mitral. So only thing is here, the mitral clip has been approved both for primary as well as secondary mitral regurgitation, but the valve replacement is under the trial. So if you see here, progression of valvular heart disease, this is the guideline. What we know is that patients with severe valvular heart disease, which is whether regurgitation or stenosis, they are the one with symptoms, that is stage D. That's the time we used to think they should require treatment, but now the guidelines are saying that even if they have severe, asymptomatic but have severe disease, we should consider treatment. First, I'm going to talk on aortic valve, and we all know TAVR has been approved about almost 12 years ago. So the question comes, what is the valve durability? These are the, patients come ask you this question, okay, if I have the percutaneous treatment, how can you compare it? So if you see that 2010, on to now. So initially was the SAPIEN valve, FDA approved, and then was the core valve that was also FDA approved. And they've gone through from extreme risk to high risk to intermediate. So this risk is based on what we call is their mortality that can happen when they go through the procedure. So there is a calculator, online calculator, so we do that for every patient. So, and we know now even low risk means younger patients who don't have a lot of comorbidities also can get percutaneous treatment, but only the guideline says they have to be above 65. So anybody under 65 will go for open heart surgeries, SAVR at this time. So this was a traditional. And what are we looking at now? So you see that, like I mentioned, extreme high, intermediate low was there, but now we're only into 2, high and low. So low risk patient, young, I'm just giving you an example, 70-year-old with hypertension and has diabetes, nothing else, and he has severe aortic stenosis. So what happened, why we are doing this is that if they are low risk, we need to be well prepared. These procedures are done under almost what we call is conscious sedation. Many of the time, patients are almost talking and very little, anesthesia. So if I will also discuss what are the rare complication happens. We will need something for backup, but those complications are very rare. So I'm just telling you, once these patients are having the valve replacement done percutaneously under conscious sedation, and that's where we are. So over the last 10 years, what have we learned? This is a beautiful editorial, so you understand the comparison of TAVR versus SAVR. All-cause mortality, if you see here, very low, okay, almost 1% or so. This is what we need to tell the patients when they come and ask you, why should I go for percutaneous versus, surgery? Because surgery has been there for over 30 years, so why I should take this newer treatment? Stroke also same, very low. Compared to SAVR, which is almost 3%, we are talking about 2% or so. Only little higher need is a need for a pacemaker, depending on the type of valve you use, about 5% or so in surgery, maybe 7 to 10% with the TAVR. And mild paravalvular regurgitation. This is something that we see when we are doing percutaneous, but usually when you are doing surgery, it is very, very low. In the initial trial where the SAPIEN valve was used, there were a few cases of valve thrombosis, but over the last 5 to 7 years, that also has disappears. So knowing all this for the last 7, 8 years, the question comes, which one is better, sour versus tower? If you see here, so only benefit of having a sour is no vascular complication because we don't enter the aorta through the groin. And like I mentioned, no paravalvular leak because they are open, looking at it and nicely sutured, so you should not get paravalvular leak. But the rest of the benefit of tower. Lower mortality, lower stroke, lower AKI, but although this one also I'll go over, there's less AFib because once you have open heart surgery, there is a risk of having atrial fibrillation post, and everything is very good. That length of stay is lower, they go back to work sooner. So which therapy is better? I think that is for you guys also as well as us to judge that. That's why more and more patients always come and say, yes, we would like to have tower. Just to go over a case, this is a 74-year-old female, history of dyspnea, angina class 3, and was found to have severe AS. And she has the comorbidity wise, look at that, GI bleed, prior PCI, good medical therapy here. So echo showed that her peak velocity was 4.2. So anything above 4, we consider it as significant, and her EF was normal. So as a part of the workup, 3 things they definitely need. One is a transthoracic echo to confirm your physical finding. Second, that they will need a CT scan to understand the exact anatomy and how the valve is, so that we can also decide on the valve sizing. The third will be to make sure that they don't have a coronary artery disease, a concomitant coronary artery disease. So patient had a cath, stents were patent, so we are okay. If there are other, there's a history of lung disease, history of asthma, COPD, we may have to ask pulmonary function test, and same thing, peripheral vascular disease, we may ask them to have a carotid angiogram, but so it is, carotid ultrasound, so these will be case by case basis, but otherwise only those 3 tests we need. So echo already confirmed, mean gradient 48 and peak, this is what it is. So patient had a CT angio, and like I mentioned, every patient will be getting a STS risk assessment, and there's a heart team. So these patients are to be seen by an interventional cardiologist as well as a surgeon in the clinic, and the risk benefit to be discussed. And once they agree, we proceed. So it was low to intermediate risk. So anything less than 3 is low to intermediate risk. So this is during the procedure, significant aortic gradient here. This is the valve deployment where you see this. We have to do few injections, but this is the core valve. And finally, it looked, there was some paravalvular leak, so you do BAV, and that was how the final deployment. And usually our gradient post-procedure is just around 5 or so. So the Medtronic valve is a supraannular valve. The tower valve is supraannular, and because of that, even after 7, 8 years, the cases that who we see now have a good hemodynamics at this time. So this patient did well and was discharged only on clopidogrel because of a GI bleed. We did not give aspirin. So this is what the patients will ask, the family will ask, especially if they are older and have multiple, what are the complications? Uncommon, rare, and serious, but they are serious. So death on the table, stroke on the table, which could happen, disabling stroke, AV block requiring pacemaker on the table, but any kind of AV block that requires a pacemaker within 48 hours, like I mentioned, is less than 10%, but usually around 7% or so. And these are all okay, vascular complication. Some minor paravalvular leak is seen, but we would never allow a major paravalvular leak, and any kind of major bleeding. Since we are going through the femoral artery, you can have any internal bleeding. Since we use dye, acute kidney injury could happen. Very infrequent that the valve that we place can migrate as we are doing the procedure. Very rare coronary obstruction. Over close to 2,000 procedures, we have had 1 coronary obstruction in front of us. Rare again, annular rupture. Since we are dilating the valve, we can rupture the annulus. All these are very rare, but it could happen. Then the question comes, okay, surgical valve has been there for so many years, TAVR valve, what happens to the valve and what is, how does the valve behave over years? So this is the SAPIEN valve, which is over 5 years. If you see here, the gradient, valve area 1.5, gradient 10, and it remained the same, no change in this valve. Then in the ESC this year, last year, they did present the 8-year follow-up of another trial where they compared the TAVR valve to SAVR valve. So why we say TAVI? In outside America, they call it as implantation. We call it as R replacement. So, depending on where the study happened, you will see TAVI versus TAVR. So if you see here, comparison of surgery versus TAVR, all-cause mortality, stroke, different, and which I already told, the same thing we saw, little higher pacemaker in TAVR, but look here, AFib is slightly higher in patients who had open heart surgery, but otherwise, this is the question patients will ask, that what is the follow-up on this valve durability, means how does the valve behave? So now we have up to 8 years of data saying that the gradient will remain the same, about 10, valve area between about 1.5 or so in this valve. Then also come, what is structural deterioration? If you see here, this is surgery versus the TAVR valve, at least half, and more important is severe. When you say severe, did it require any treatment? So need for any kind of a severe valve deterioration requiring treatment, again, significantly lower here in TAVR with the P of 0.0, towards trend. Now, so this is the central figure here, which is saying, so when the patient comes to you, what will we offer, right? So if the patient is old, I would say 80 years and old, we all know. The first will be TAVR, and if he lives 10 years, we can do another TAVR. We're not, that will be over 90, what will happen. But if the patient, like I said, if it's less than 65, there's no option, should go for surgery. 65 to 80, what can we do? So you have a heart team, talk to the patient, talk to the family. And based on that, we can decide, is it TAVR or SAVR? Any of these are okay. Then they come back in 10 years. What would you offer, right? Again, could be okay, TAVR or SAVR. Or if they only want TAVR, just look at this, TAVR and TAVR and TAVR. Okay, we are all ready for that. 3 times. So that's going to be the future. So what are the newer and emerging indication? There are multiple, they are ongoing. So even for bicuspid, there's ongoing, but one important thing that we need to know, these are all ongoing trials, so maybe by next year or the year after we'll present it. Important trial that we need to know, because we get several phone calls from physicians like you asking what happens if they have only pure aortic regurgitation. So what is the difference? Stenosis versus regurgitation. In stenotic valve, there is calcium. So when we place the valve, the calcium holds it. So, in the open heart, they go inside, they suture, so the valve sits there. So always is like, okay, why the valve doesn't come out? So it does not, because the calcium is holding it tight. In pure AI, usually you never see the calcium. So they had to make a different kind of valve, not the usual valve that we use. So this is a different kind of the valve where they can actually anchor to the aorta so that they do not come out. So it looked a little different, angiography. So this is right now under trial called the GINA valve. And they did present it recently during Euro PCR, saying the initial 45 cases with good results. Other thing that we also face is that patients, once they have come with the TAVR, surgical valve, they are shorter and they place in such a way that the access to coronary arteries are very easy. Once we are doing TAVR, we are, right now we are learning, but even otherwise coronary access could be challenging. So this was an app that we Sinai created, how to re-access the coronary artery through the TAVR valve. One is, the above is the core valve, and this is the SAPIEN valve. Currently, these are the 2 commonly used valves. So now in 2022, if a patient comes to you, right, it's not a question who should get TAVR. like less than 65 should go for surgery. So 65 to 80, this is the age group that we see. Who should be going to SAVR? That should be the question. Who should be going to surgery? So low to intermediate scale, but extensive coronary artery disease, left main 3 vessel disease with aortic stenosis, age of 68. Okay, that patient should be going for surgery. Bicuspid valve with hostile anatomy, and I'll show you what hostile anatomy is, heavily calcified and just one raphe. These kind of cases will have a lot of paravalvular leak and risk of annular rupture. Again, young age we said because of future valve degeneration. Concomitant aortic root dilation. So if they need aortic root repair and all that along with this aortic valve, they should go for surgery. And heavy calcium in the annulus alveoli. Bioprosthetic, what we are saying is it's approved, but only for intermediate to high risk. So if it's low risk, bioprosthetic valve degeneration should go for re-op at this time. And unfavorable anatomy, coronary height is very low. And when we place the TAVR valve, there's a risk of obstruction. That's also bad. Too small annulus, you don't have the size of the valve. Concomitant mitral valve or tricuspid valve disease with low surgical risk. So these are the group of patients who should be going for SAVR at this time. So look at this chunk of calcium. So when you place the valve here, the paravalvular leak can happen, one, or could be annular rupture when you're dilating it. This is that calcific bicuspid raphe where we will not be able to crack it open and can give rise to paravalvular leak or aortic annular rupture, low coronary height and risk of obstruction when we place the valve. So if you see here, currently right now 85% of the patients over the age of 65 who are being referred to us get a TAVR at our institution. So this is just an overall perspective, what is happening out in the world. So in 2015-16, low risk was approved, and ever since that, isolated aortic disease, aortic stenosis was treated, and that's when the TAVR volume actually took over. And just have an idea what's going to happen. They're close to 72 to 2021, 2022. We are going to probably cross 80,000 procedure 1 year, and look at this SAVR, it is stable at this, about actually going down here. So 80,000 procedures in a year. So from 2011 to 19, sites performing TAVR, about 700. And look at the outcomes. Outcomes of 30-day, 1 year, everything. In hospital, about 1% or so, 30-day, less than 3%. So these are the important numbers that we need to know. And the access site. Look at that. Over 95% of the access site is just femoral. So other access which are not discussed is rarely done. This is the Mount Sinai numbers from last year with very length of stay just around 3 or so with a good observed mortality rate. And this is the number we're likely to reach this year. Every case that we do, we have to enter the data into what is called as a registry, TVT registry, as well as there's an ACC NCDR also that also. So we always like to compare to see where we are. So this is Mount Sinai in yellow, TVT registry. If you see here compared to what other people are doing outside, we are very good. Look at our 30-day mortality, 0.5, 1 year mortality, 7.6, CVA, 1.5, very low vascular complication, slightly higher pacemaker rate, and look at even readmission, because this is very important, because CMS and reimbursement is all dependent on how these things happen. This is the national benchmark and comparing ourselves. Look at the bleeding, what the benchmark, and we are at 2.7. And moderate to severe PVL, 0.02. Based on all our procedural outcome and what we enter, we now have got 3 stars. And what did they look at the 3 stars? 30-day death, 30-day stroke, life-threatening major bleed, acute kidney injury, okay? And more important also, paravalvular leak, that's included. So you just cannot say that you have to do not a good job, a great job. If you leave any paravalvular leak, they will track it. So this is the Thoracic Society as well as American College of Cardiology, and then your marks will go down. So we have to do a great job. Now coming to antithrombotic therapy post-TAVR. A lot of the discussion has happened on antiplatelet and antithrombotic therapy. So if you, the two important trials we see here. So despite lack of evidence, a combination of low-dose aspirin and a thionepyridine was used after, again, this was in Europe, so they're using the word TAVR after percutaneous, TAVR as well as, so no data, but that's what they used. So to see what happens with these patients, these patients did not require oral anticoagulation, so they called cohort A. So if for any reason patient require oral anticoagulation, the most important reason is atrial fibrillation. So what will happen in those people? What's the kind of antiplatelet therapy we need to give after TAVR? So that was cohort B. And what did they show in cohort A? Remember this, patients without need for oral anticoagulation. So they used aspirin alone, aspirin plus clopidogrel. And what you see, like shown by Dr. Mehran, was that increased bleeding. That when you have two agents, there's increased bleeding with no change in ischemic stroke, MI, or any other thing with mortality. So again, we are coming to the same point. Do not give two agents. If it's not indicated, don't give two agents. Just aspirin is good enough. So that is what, I mean, you will see that this is what the current is, and the future is going to be aspirin. They already made it to the guidelines right now. So the second part is, if they need oral anticoagulation for any reason, and most important is AFib, what will you do in this patient? So they all got NOAC, and after that, they were again randomized to just oral anticoagulation or oral anticoagulation plus clopidogrel. And same, whenever you add an extra agent, bleeding increases and no change in mortality or ischemic event. So currently, what is happening, what we do is that you're giving any of this agent, warfarin or NOAC, with one of this agent. So the future will be no need to give aspirin, clopidogrel. You can just continue an oral anticoagulant agent. So the guideline is very clear. For straightforward TAVR procedure, just use aspirin, and then it is a 2B that if you want to use aspirin plus clopidogrel, and 3, which is very harmful, that if in the patients do not give any kind of NOAC along with the aspirin in this patient because there's a risk of bleed. Now, one of the complications that I mentioned, and one thing that patients do not want to have, and you often complain, is that if they had a stroke, major stroke or even a minor stroke. Minor stroke means they're not able to walk, not able to see, memory loss, all these things can happen. So we know the incidence is there. Why does this happen? This happens because you have a lot of calcium, like I mentioned, and where you're going there, we are opening it, we are putting a new valve. So what's going to happen to the debris and the calcium? It has to go somewhere. The commonest area is up in the head. It could be the aorta that is all calcified, if you see it here. So can we catch this debris, right? So there is a way to catch the debris, and you have seen this, that the debris were caught. The one that has been approved and we use right now is called as a Sentinel device. Just to tell you, over years, the stroke numbers have remained the same. Nothing has changed. So we don't know how can we change it. But if you have had a stroke, there is a major issue with the for the health of patient, as well as they do not like this because they are going to go to a nursing home, something else, and a significant financial strain on healthcare. So all these things need to be avoided. So this was one trial that came out earlier, which showed that the Sentinel device, the one that device I showed, was safe. And then there was no statistical difference, but definitely some decrease in the stroke, a little trend in stroke decrease to 72 hours. So what they did, let's do a randomized large trial, and this is what was presented during the TCT. This just completed on 3,000 patients, what was called as protected TAVR. Another one is ongoing of about over 7,000 patients results have not been protected. So, sorry, presented. So what did they say? So patients who got this protected device, and if you see here, extreme risk, intermediate risk, both were equal. So one got the cerebral protection and one did not get the cerebral protection. And most of them, if you see here, tricuspid valve, very rarely bicuspid or bioprosthetic valve. And what did it show? That overall, no difference. But disabling stroke in the yellow, you saw that it decrease or disabling stroke. Same thing here. Non-disabling stroke, no difference. Disabling stroke, some difference. So if you see here, it was equivocal, saying that there's a lot of media right now saying that not sure whether this device has to be used or no. So whenever patient comes, if they have risk factors, risk factor is that they have prior CVA, they AFib with CHA2DS2-VASc score of more than 5. Those kind of patients are the one. And prosthetic valve and heavily calcified valve, where we know that when we are doing the tower, it might embolize. We discussed that they will get the sentinel. It is not routinely being used right now. Then moving on to mitral valve. So if you see here, mitral valve therapies based on the TVT registry, you know the numbers. The tower numbers are about 700 sites. So if you see here, what do we use for mitral? One is clip, other one is valve replacement, percutaneous valve replacement. So the sites are about 400 or so that are available in the United States, and majority of them get edge-to-edge repair, which is mitral clip. It's called as edge-to-edge repair. So look at the procedure numbers. They were close to 75, 80,000 procedures a year. We are talking about 10,000 procedures a year, and valve replacement just about over 1,000 or so. Then question comes, which kind of patients? Like I mentioned, majority of them are primary. Secondary MR was approved a few years back. Mixed pathology, all kind of patients get this. So this is just a case presentation, a 79-year-old female, multiple comorbidities here, EF of 25. So it's again mixed pathology on this patient. And this patient's one thing that we need to know, if they're secondary MR, that means EF is low, dilated, they need to be on medical therapy first, which just includes likely an beta blocker, ACE inhibitor, or diuretic therapy. On therapy, if they continue to have mitral regurgitation, that's the time we can place the valve. So here, like you said, was mixed. You see a nice prolapse here in the 3D echo, and severe MR on the 2D echo. This is done a venous. Tower was arterial procedure. This is venous. We have to go from the right side, do a transeptal, and go on to the left side, and then this patient required 3 clips. So after 3 clips, you see that the severe MR is now become mild, okay? So this is the 3D, you can see 1, 2, and 3 clips that were placed here. Also what we do is, through the same guide catheter that we use, we can measure the left atrial pressure. So if you see here over 80, after first clip goes to 50, then goes down to 35, back down to 20. Before we release the clip, we want to make sure we do not cause stenosis of the valve. And once we know we do not cause stenosis, then only go to our second clip or so. So 30-day outcome, again, we need to know this number when the patients come to us or they ask, single leaf detachment, that you place the clip and then one leaflet gets detached, still about 1%, but most, look at it, MI, TIA, stroke, everything is about around 1% or so. Same thing that you see in the national level, that at 30-day mortality, that was 30-day mortality about 5% or so, and stroke rate is just about 1.5%. Now, if this is an important thing that note, that if you see black, which is NYHA class 3 and 4, once you have treatment, look at that, they become 1 and 2. So what happens? You give once you have done the clip, they will need some kind of treatment, which means if they're on diuretic of 120, 80 milligrams of Lasix or anything, they'll go down to maybe 20 or 40, but some kind of a treatment will continue. The clip that I just showed you belonged to a different company, and our second company came back with a newer clip, and they compared it same. Overall, they did very well, and this is a clasp trial, the different kind of a clip. They came with the ACE implant. Now they're able to see this clip is as a different kind, and they, since mitral clip, that the first clip that I showed you was already been approved, any new device that come, they have to compare it to the approved device. So that is a trial which showed, only thing the little bit procedure time is slightly higher since there's a learning curve. But other than that, it was comparable to the mitral clip that has been was approved. So based on this trial, we now have a FDA approval for this new one, which is from Edwards, which is called the Pascal. Now moving on to, I discussed the clip. Now we are going to replacement of the mitral. Again, same, about 300 centers or so. And who should be getting the percutaneous mitral valve replacement? Valve in valve. So patient already had a prior mitral surgery and now has dysfunctional mitral valve. Valve in ring, they had a previous mitral surgery and now they have a ring there. And very rarely valve in MAC. Valve in MAC means there is heavily calcified mitral valve annulus, and we can place, so that gives rise to stenosis most often, and can we place a valve in that? So just look at the outcomes. So valve in ring, okay. Valve in MAC. Look at the outcomes here is almost mortality at 30 days is close to 25%, which is not a good outcome for us. And otherwise complications are comparable, less than 1%. TMVR devices, when you see over 10 devices and not a single device look like each other, you know there's something wrong. So look at this. Not a single device that will look like each, but these are all, we are part of a Medtronic Intrepid trial. This is the Abbott device. So these are the two that are being tried here. The reason for that, different devices, is compared to aortic valve, where it is calcified, circular. This is oval. So you have anterior leaflet, this aorta, the posterior mitral leaflet, and it's oval, and look at all different things. So the biggest concern for us is that when you place a valve, you can create a problem with the LVOT. So you don't know, which way a patient can benefit or would not benefit from the devices that they are out there. So that is why this is a little more complex than TAVR, but that's okay. That's what interventionist cardiologists like. We need challenges, and that's what the devices will be. So this is the Tandem, which has been already done in many patients, and you see there good results with the device. And this is the functional, MR assessment post, which again says, which is very good. They have done it up to 2 years or so. We are part of this device, which is Medtronic device. Initially used to be apical. Now they have transfemoral access via the vein. It's a large sheath, has to be a cut down. And there are two size devices, 24 and 48 millimeter valve, depending on the patient's annular size, different kind of valve will be used. So initial roll-in has been done, and then they will be randomized. So this is the initial trial with the roll-in cases, which showed that mitral regurgitation and NYHA class definite improvement at 30 days in these patients who got the valve with the, very mild LVOT obstruction, which I had discussed there. So coming to same, I said the pathology is very complex. Based on that, when you send a patient, if has MR, we can decide whether they will benefit from a clip, which is edge-to-edge repair, or TMVR. There are various reasons to consider who will benefit from what. There are two ongoing trials, which is repair MR, which is comparison of clip to open heart surgery here, transcatheter clip versus mitral valve repair, which is going to be controlled. This is a head-to-head now from percutaneous to open heart, and another one is primary trial, again the same. that we are doing. So here in Mount Sinai for mitral clip, this is the number we have from 2021 and 2022. That's what it is. So again, we like to always see where we are compared to the nation. This is the data where if you see here the MR post reduction of Mount Sinai. A nation is 1.3, we are 1.1. And like I mentioned, we always check the gradient, which is very low compared to the nation. And look at this, device time, half to what the nation's device time is. So that we have actually Sinai has mastered this technique. And finally, going to just show you something about tricuspid valve, prevalence about 2.4 million and undertreated. Okay, only 10,000 patients get a surgery. There's not a lot of medical options available for this. Again, when you see several devices, we know there's not a single device that will work. Coaptation device, then there's a ring, there is a clip, there's this valve that goes into inferior vena cava so that the blood return is decreased. But this was the result of the mitral clip that is being used in the tricuspid area. The mitral clip that I showed, it's being used in the tricuspid area. And then we are actually part of this study, which is TriLuminate study. Roll-in has been done. And then there will be a randomized, which is 1-to-1. And this roll-in was presented in TCT, showed that the device is good compared to medical therapy. Other the one that is ongoing, actually this has been presented. This is the Evoke, and this is a valve that's going to go into the tricuspid area. Very simple device. You see there, it goes, it anchors tricuspid. And then when we think, when the echocardiographer says, yes, you have in the right position, we will just release it. So this data was presented last year. Again, symptomatic, severe TR, patients has multiple comorbidities. Look at that, multiple comorbidities. And results were very good, saying that TR decreased significantly in this patient. Less than 1 plus, TR, less than that in 92% of these patients. This is how the echo in these patients look at 6 months. Again, same. Most of them were just none or mild tricuspid regurgitation. And this is the ongoing trial that is there. So just to conclude, I think this will be the take-home message for everybody who has been listening to me. TAVR is appropriate in all-comer severe AS patient and comparable valve durability to the surgical valve. Its role in asymptomatic and moderate AS patient is under trial. So we can tell them very clear, less than 65 should go for surgery. Anybody above 65 should get a TAVR. And I've already showed you 7 criteria who should be going for TAVR. Then once they have TAVR, aspirin alone, there's no need for oral anticoagulation for these patients. Aspirin alone is good enough. If there is any indication for oral anticoagulation, long-term, which is usually atrial fibrillation, only continue that. There's no need for additional clopidogrel or aspirin. But if they have concomitant CAD, indication for any kind of antiplatelet agent, then consider, if there is CAD, just consider to give clopidogrel. Now, same thing with a stroke prevention device, not effective, but can reduce severe disabling stroke. So they should be used in certain high-risk patients only. And same tier or clip is safe, effective in reducing heart failure symptoms, hospitalization, mortality, as mortality in functional mitral regurgitation. The other devices are under trial, and they are promising based on the results. And finally, the tricuspid valve devices for severe TR have a great future. You've seen the new ones coming. Why would do that is that you master all these techniques, so you have better outcome and good survival for our patients. So any of this what I meant is these cases that we have discussed, we actually have what we call our CCC live cases, where we do complex coronary every third Tuesday, structural every the Tuesday of every other month, and there's peripheral also. And for anybody who wants to learn more on intervention, we have apps that can be downloaded, and this will be the future educational apps that will be coming between this and next year. Thank you for your attention.